A very good evening, MRCP Part 1 aspirants and our honorable faculty. Today's the class is about cardiology, which would be conducted by Dr. Sankha Subhra sir. He's a senior consultant at Interventional Cardiologist, Apollo Multi-Speciality Hospital in Kolkata. Over to you, sir.
Good evening, everyone. Welcome to this session of MRCP Part 1 on cardiology. So the first question, a 62-year-old gentleman was suffering from systemic hypertension for long. Initially, he was on amlodipine, but even after maximum dose of it, the BP was not controlled. So subsequently, hydrochlorothiazide and losartan also being added to control his blood pressure. But even after administering 3 different antihypertensive drugs, the BP remains uncontrolled. The physician added 𝐼𝐴 to combat the BP. Now, 𝐼𝐴 acts by which of the following mechanism? So
renin inhibitor.
Pardon?
Renin inhibitor. Option C.
Option C. Direct renin inhibitor.
Yes, sir.
Yeah. So, do you use 𝐼𝐴 normally in our clinical practice?
It's quite expensive.
Quite expensive. No, normally we don't use 𝐼𝐴 in clinical practice. It is not because of cost, but 𝐼𝐴 was primarily tried in heart failure patients. So there were 2 trials where 𝐼𝐴 was tried in heart failure patients, but both of the trials either showed no result or increase in mortality. So 𝐼𝐴 has been abandoned from using in either hypertension or heart failure patients. So 𝐼𝐴 is a direct renin inhibitor. So it binds with specific receptors over renin, and it inhibits the conversion of angiotensin to angiotensin 1. So that is how is the mechanism of action. Now tell me about this patient who is on calcium channel blocker and ARB, angiotensin receptor blocker, and also on a diuretic. But still his BP is not controlled. So what will you like to add? Not about 𝐼𝐴, what about the other drugs?
The potassium level and then add spironolactone.
You can add spironolactone, yes. You can block the aldosterone pathway. Any other suggestions?
Beta blocker.
Beta blockers, fine. Beta blockers are not a very good antihypertensive drugs, but still, yes. If you add a beta blocker, which one will be better? A simple beta blocker or an alpha beta blocker? Do you know the various beta blockers? Tell me a few.
Nebivolol, carvedilol.
Nebivolol, carvedilol, what else?
Atenolol, atenolol, metoprolol, all sir.
Yeah. So atenolol, bisoprolol, nebivolol, these are mostly selective beta blockers. Among them, carvedilol is a drug which is an alpha beta blocker. So this is a blocker which has a significant hypotensive effect. So carvedilol is a better option if you think of reducing blood pressure, if you think of adding a beta blocker. You can add aldosterone receptor antagonist. You can add vasodilators, direct vasodilators like hydralazine. You can add centrally acting sympathetic blockers like clonidine or methyl dopa. So these are the various options that you have when you can't control BP with the first-hand drugs. But be careful that you have to go to the maximum tolerated dose of a single drug before you combine 3 or 4. So that is important. Next question. A 30-year-old young man was subjected to ECG after his elder brother, aged 33, expired from sudden cardiac arrest. The ECG revealed T inversion in lead B1, B2 with presence of 𝑓-silent wave. What is the most probable diagnosis?
Brugada syndrome.
Brugada syndrome. Anyone else? Where do you get an epsilon wave? Do you know, have you heard about this wave, epsilon wave?
Epsilon wave.
It's a wave, a notch which is present just after the 𝑞𝑉𝒆 complex. Normally, the patient presents with right bundle branch block in V1 and V2. And this wave appears just after the RBP configuration, in between 𝑞𝑉𝒆 and T wave. And it is a very classical wave found in. Any other suggestion?
Hypertrophic cardiomyopathy. But sir, it is Brugada syndrome.
So let me clear it up. It is basically ARVD, arrhythmogenic right ventricular dysplasia. So here we get epsilon wave. Whatever you are telling, Brugada syndrome is basically you get a right bundle branch block in V1 and V2 with elevation of ST segment in V1 and V2. That is called Brugada syndrome. In Brugada syndrome, patients often have sudden cardiac arrest during sleep, which is very common in Brugada. But in arrhythmogenic right ventricular dysplasia, there is a fibrofatty replacement of the RV myocardium. There is a triangular zone inside the RV in between the tricuspid valve, the RV apex, and the RV outflow tract, which shows fibrofatty replacement. And the VT comes from this focus. So it is a VT originating from the right ventricle. And the configuration of the VT is LBB morphology. So LBB morphology VT arising from right ventricle. And these patients often land up with sudden cardiac arrest. And if these patients have an episode of survived sudden cardiac arrest, then these patients often qualify for an ICD. So please remember, epsilon wave is found in arrhythmogenic right ventricular dysplasia. In Brugada syndrome, you get right bundle branch block with ST elevation in V1 and V2, which is basically a cause of sudden cardiac death at night during sleep. Okay. The next one, a 70-year-old gentleman came to the endocrine clinic with complaints of increasing fatigue, poor healing of his left leg ulcer for long duration. Recent investigation showed uncontrolled diabetics with signs of local infection of the ulcer site. His surgeon advised him for good diabetic control. On detailed discussion, it was revealed that he was suffering from chronic heart failure. It is currently controlled with carvedilol, ramiptal, and torsemide. Among the following hypoglycemic agents, which one should be avoided for this gentleman's glycemic control? Pardon?
Pioglitazone.
Yeah, so this patient is suffering from a leg ulcer. Recent investigation shows uncontrolled diabetes. Revealed that he was suffering from chronic heart failure. So which anti-diabetic drug is known for fluid retention? That is glitazones. So pioglitazone is the answer, right? The other drugs can be used in heart failure patients. And the preferred drug that is now used is the dapagliflozin, the sodium glucose cotransporter inhibitors. Which of the following is not true about atrial septal defect? Wide and fixed splitting of second heart sound. It is characterized by left ventricular volume overload. There may be functional tricuspid stenosis. ECG shows right bundle branch block. And Luttenbecher syndrome is characterized by ASD with rheumatic mitral stenosis. Any suggestion? Atrial septal defect.
Is there functional?
Left, B. Is it
Which
B?
is not true. I've asked you which is not true about ASD. So be careful about the term.
C is not true, sir.
Pardon?
C is not true.
B. I mean the second one. Is it the second one?
Oh, sir.
Okay. Others?
Second.
Second
B.
one.
B for
So what happens in ASD? Which ventricle is overloaded?
the right ventricle.
The right ventricle. How is the shunt? Tell me about the shunt. The direction of the shunt.
Left to right shunt,
It's
sir.
left to right shunt. That
Right
takes
the volume
place.
overload.
So from left atrium to right atrium,
E is
right
wrong.
atrium to right ventricle, from right ventricle to pulmonary artery. So there is right ventricular volume overload. And due to increased flow of blood across the tricuspid valve, there may be functional tricuspid stenosis. That is what I have written. So there may be functional tricuspid stenosis due to increased flow of blood across the tricuspid valve. So the first heart sound may be loud in this case. And 𝐷 syndrome, this is true. Often ASD patients can have an associated mitral stenosis of rheumatic origin, and this is called 𝐷 syndrome. The ECG in ASD shows right bundle branch block with right axis deviation. That is commonly found in ostium secundum ASD. If it is an ostium primum ASD, then you get a right bundle branch block with left axis deviation. So you are right, the answer is B. It is left ventricular volume overload. A 65-year-old lady came to the cardiology clinic with history of recurrent episodes of peripheral vascular disease for the last 2 years. She had undergone embolectomy surgery previously for her vascular disease. On detailed discussion, she revealed that she is allergic to aspirin. She had no other history of embolic manifestations like ischemic stroke, transient ischemic attack, apart from her peripheral vascular disease. Her ECG was showing normal sinus rhythm. Echo showed good functional activity of the heart. Among the following drug, which one has reducing capacity in vaso-occlusive events? Warfarin, clopidogrel, dabigatran, dipyridamole, and apixaban. Any suggestion? So this patient is suffering from peripheral vascular disease. What do you normally prescribe in peripheral vascular disease?
The clopidogrel, cilostazol, this group of drugs.
Normally you give antiplatelets. Now this patient is allergic to aspirin. So you can't give aspirin. So the other choices are the other antiplatelets. Clopidogrel, cilostazol. Pardon?
Clopidogrel.
Clopidogrel, yes. Can you give warfarin, dabigatran, anticoagulants?
They'll need more monitoring.
Because the patient does not have any history of embolic manifestations. So as such, anticoagulants are not indicated. But in recent trials, there is one newer anticoagulant which has been used in coronary as well as peripheral vascular disease. You should know it. That is rivaroxaban. A low-dose rivaroxaban in the form of 2.5 milligram twice daily has been authorized to be used in peripheral and coronary artery disease. So this is the first anticoagulant that can be used in ischemic heart disease as well as in peripheral vascular disease. Rivaroxaban 2.5 milligram BD. This is a new introduction. But otherwise, for peripheral vascular disease, you will use antiplatelets, either aspirin, clopidogrel, or cilostazol. A 38-year-old male presented with recurrent palpitation. Bolo. I'm at a class niche for a competition. So a 38-year-old male presented with recurrent palpitation. He is normotensive, non-diabetic. His echo revealed asymmetrical septal hypertrophy with features suggestive of HOCM. He had a resting LVOT gradient of 60 millimeter mercury, and ECG is showing atrial fibrillation. What is the best management strategy? ICD implantation, bisoprolol, septal myomectomy, alcohol septal ablation, and digoxin.
ICD implantation.
ICD. So what are the indications of putting an ICD in a patient of hypertrophic obstructive cardiomyopathy?
Irregular heart rate.
Pardon?
Irregular heart rate.
Outlet obstruction, is it?
Yes, outlet obstruction and irregular heart rate.
Irregular heart rate is not an indication for putting an ICD. Sorry.
Outflow obstruction with this, sir.
No. Outlet obstruction with irregular heart rate is not an indication of putting an ICD in a HOCM patient. So I'll ask others to suggest.
Bisoprolol, beta blocker.
Yes, you're right. Bisoprolol, rate control is needed. What is needed for HOCM patient? Beta blockers can reduce the LVOT gradient. It can control the heart rate as well. But if this patient is having a chronic AF, then you have to add one more drug. What is that? Yes, students? If this patient goes into chronic AF, what another drug you need to add?
Anticoagulant therapy.
Yes, very good. Anticoagulant therapy. So either you can give vitamin K antagonist or you can give the newer anticoagulants. But normally we give vitamin K antagonist in HCM patients. Now remember, students, that indications of putting an ICD in an HCM patient is anyone who has survived an episode of sudden cardiac arrest, or if he has an episode of syncope, or if his LV wall thickness is more than 30 millimeters, or if he is hypotensive during exercise. So there are certain criteria which, and if he has a high risk family history, if there is a first degree relative who had a death of cardiac arrest. So these are the salient features where you need to put an ICD. So first degree relative having a sudden cardiac death, significant hypertrophy, muscle thickness more than 30 millimeter, history of syncope, past history of survived sudden cardiac arrest, hypotension during exercise, and if there is if you do a MRI, then if there is a contrast enhanced MRI shows significant fibrosis, then these are the indications of putting an ICD. Okay. So the answer is bisoprolol. A 27-year-old female came to emergency department with complaints of palpitation, shortness of breath, and retrosternal chest discomfort for the last 3 to 4 hours. She had similar episodes like now in the last night also. On examination, she is conscious, alert, with sweating profusely. Blood pressure is 74/52 with steady pulse, tachypnea. She is afebrile, saturation is 92% in room air. After administering supplemental oxygen and establishing an IV cannula, you did a 12-lead ECG which showed a narrow 𝑞𝑉𝑰𝑫 tachycardia with a heart rate of 170 per minute. What is the best next course of therapy among the following options? DC cardioversion, verapamil 10 mg IV, atenolol 50 mg IV, adenosine 6 mg to 12 mg IV, amiodarone 300 mg IV.
Direct current DC cardioversion.
Because the patient is with hemodynamic instability.
Yeah. So if the patient had a BP of 120/70, then what we'd have done? If this patient had a BP of 110/70, what you would have done?
Adenosine.
Adenosine. So why do you give adenosine?
PSVT, sir.
So what is the preferred site where you give adenosine? Will you give it through a peripheral vein or a central vein?
Central vein.
Huh?
Central vein, right? And then we wait for 6
choose
seconds.
a big thick vein, preferably a central vein. And you need to give it a fast bolus. And before giving adenosine, do you need to ask the patient anything?
If they have asthma or
history.
something, asthma.
Yeah. You need to ask the patient whether he has any history of reactive airway disease or any history of conduction disturbances. So if adenosine acts, it's fine. Say if adenosine fails, the patient is still having an SVT, adenosine has failed. What next?
Carotid sinus massage or press the eyeballs.
Carotid sinus massage, fine, that's good. Valsalva maneuvers, carotid sinus massage, they have failed.
Then
They also blow in a syringe, right? A 10 mm syringe. They make them blow in a syringe, and then get them upright or something. There was that maneuver they do.
No, I'm asking you what is the next drug? If adenosine fails, what is the next drug?
Beta blocker.
Beta blockers. Do you think you will give atenolol?
No.
What will you give?
Can we give amiodarone?
No, sir. I think.
Any other suggestion?
Calcium channel blocker, 𝑽𝒑𝒑.
Yes. So calcium channel blockers are much better compared to beta blockers in SVT. So either you can try with verapamil 5 to 10 milligrams slow IV, or you can try with diltiazem, which is also equally good, 0.25 to 0.35 milligram per kg body weight slow IV. So verapamil or diltiazem are a better choice. So these are the therapies that you try, and if all this fails, then you can try with IV amiodarone. That is also a good choice, but if the initial drugs fail. And you also need to see the LV function. If the LV function is compromised, if the patient is having a low LV function, then it is better to give amiodarone compared to calcium channel blocker. So the answer for this question is DC cardioversion, since the patient is hemodynamically unstable. So what is the amount of current you will use for SVT? How much current?
100 joules.
50 to 100 joule is enough. 50 to 100 joule is enough for SVT.